Alrighty, well, welcome everyone to this week's installment of AMSSM's National Fellow Online Lecture Series. My name is Matt Wise. I'm one of the current sports medicine fellows at the University of Utah and have a background in family medicine. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on sexually transmitted infections that will be given by Dr. Niro Liu 1 week from today at the same time. Moving on to tonight, I'm very excited to welcome Dr. Aaron Provance to speak to us on apophysitis. Dr. Provance graduated from West Virginia University School of Medicine, where he also completed his pediatric residency prior to doing his sports medicine fellowship at the University of Colorado. A few years after fellowship, he became the medical director of the Sports Medicine Center at Colorado Children's Hospital and served as the assistant fellowship director for the pediatric track at the University of Colorado for several years. In 2002, he moved across the Rockies to become the pediatric sports medicine director at the University of Utah. He also is the team physician for Real Salt Lake affiliates for Real Monarchs and the RSL Academy teams. Before we get started, we also like to mention the goals of the National Fellow Online Lecture Series, which are to serve as an adjunct to your individual program's educational content, provide fellows with direct access to educational experiences with AMSSM members, and at times invite guest experts in a variety of formats, and to assist in CAQ exam preparation. And lastly, reminders to please mute your device's microphone and turn off your video. Go ahead and submit questions through the chat function on Zoom. I'll be monitoring this throughout the talk. And the moderator, myself, will ask the questions during the Q&A at the end. We don't have an evaluation for the end of the lecture. So now, without further ado, welcome Dr. Provance.
Thank you very much, Matt and Andy, for putting all this together. I'm going to go ahead and share my screen. Can you see that okay?
Looks great.
Perfect. All right, and thank you to AMSSM and the Fellowship Education Committee for putting this all together, making this possible. So we're going to talk about apophyseal injuries in young athletes tonight, and I have no conflicts of interest. So a little outline about what we're going to talk about. Apophyseal injuries are both overuse in nature, so apophysitis, and we have acute injuries to these same areas, or avulsion fractures to the growth plate. And I'm going to throw in some about 4 different types of osteochondrosis at the very end of the talk, and we'll talk about those. And then we'll have 3 CAQ style questions for you at the end, where we're going to have some audience response and go through each of those in detail. So jumping into the apophyseal injuries. So a little review of the anatomy of the bones. We'll go through the physis and the apophysis, what's the difference between them, review the important histological differences, and historically, like if it's an acute injury versus a gradual onset of pain, highlight very specific apophyses, and then talk about the avulsion injuries that occur at those same spots. So looking at the anatomy of our skeletally immature athletes, much different than our mature athletes, of course. So we have the physis, which in this picture you can see. Can you guys see my cursor okay? Yep, perfect. So this is the distal femoral physis. Another example of a primary growth plate is the proximal tibial physis right here. So those growth plates are primary growth plates that are responsible for the overall length, or in the lower extremity, in this case, would be responsible for the height of the athlete. The epiphysis, I typically think about as the pressure aspect of the joint. So it's the area of bone between the joint and the growth plate. And then, of course, the apophysis. And this is where we get a traction injury in young athletes. And this is a secondary growth plate. So it is not responsible for the length of the bone, but is responsible for building that bony tubercle or tuberance that the tendon attaches onto. Of course, in stages of peak height velocity or rapid growth, we can have extra pull on this area. So growth and development, just a reminder of the ages of pubertal onset for females and males. Looking at peak height velocity or PHV, we see that males tend to go into their peak height velocity at a little bit older stages, like Tanner stages 3 and 4. And so how does that change things? Well, injuries are more common in the adolescent growth spurt. So we see this increase in body mass. We see an increase in height, of course. We see imbalances in growth and strength. We have a lack of lean muscle tissue or lean muscle mass. And that the muscles do eventually catch up. But of course, the bones are growing fast. We do see some increase in joint hypermobility around this time in growth. But more importantly is that we see the physis is less resistant to physical stress. So we see overuse injuries, like for example, in the distal radius in gymnasts. We get changes in the metaphyseal blood supply. Whether the apophysis is also less resistant to traction stress, right? So we're growing really fast. The muscles and tendons are getting very tight, and the apophysis is growing very quickly. So it's like this perfect storm to have inflammation at the apophysis. So importance of history. So, this is extremely important when you're trying to decipher between acute avulsion versus just a gradual onset of apophysis, right? So acute avulsion injury, they won't have or unlikely to have pain in the area before the injury. In some cases of like pelvic avulsion fractures, we can see that. And even in the elbow, we can see that. But most of the time, it's a gradual onset of pain with apophysitis, where an apophyseal fracture, it's a rapid onset of pain. They feel a pop. A lot of time in the lower extremity, they will drop to the ground and have difficulty weight bearing. Where is the pain? Of course, in sports medicine and orthopedics, anatomy, bony structures, being able to palpate those areas, extremely important, right? So knowing where your physis is, knowing where these apophyses are, right, is very, very important. And then the age of the athlete, as you'll see in many of these, is a big determination on if that apophysis is open or is it going to be closed. And then you may start thinking of something else in your differential. So here's the list of chronic apophysitis that we see in young athletes. So Osgood-Schlatter, of course, is the big star here. It's the most common thing that we see across the board. Sever's, I think, is a close second. But some of you may have not have heard of Sinding-Larsen-Johansson, which is like the younger cousin to Osgood-Schlatter's. We have Iselin's. Again, some of you may not have heard of that. Base of the fifth metatarsal. Ischial, ASIS, AIIS, medial epicondyle, and then also one that's not as common, olecranon. So we see this in our young throwers where the triceps attaches onto it. And I always ask the fellows this question is, where are the two lowest risk areas for fracture? And I'll just throw it out there. Sever's is very unlikely to have an avulsion injury, and then the olecranon. Those are the two major ones. There are two that are really high risk, and we'll get into that here. So general approach to apophysitis, usually pain-guided activity modification. A lot of times we talk about maybe dropping the activity to 50% intensity of training volume. But there are two exceptions to this, and these are the ones that are high risk for avulsion injury. And that would be your throwers with the medial apophysitis, medial epicondyle apophysitis, or the growth plates around the pelvis. So those athletes, we do shut them down and we make sure we get the pain to resolve and then work on physical therapy before we return them to sport. And then symptomatic therapy, of course, with icing, NSAIDs, bracing, straps. And we'll get into all the details of what kind of things you can use for each of these. Physical therapy needs to be focused on eccentric strengthening, probably the most important thing to work on. But we can't forget about the proximal muscle control. For example, Osgood-Schlatter's, we're kind of looking at the hamstrings and quads quite a bit, but you can't forget to focus on the hip muscles, the pelvic stabilizers. You want to have great, dynamics, biomechanics of that lower extremity to keep everything in line to decrease stress on that growth plate. And these are generally self-limited and go away with time, but we will go through some of the things that can happen, complications that can happen long-term with these more severe cases. I usually see them back and follow up if there's change in character or location, or if things just aren't improving, especially if it's the two I just mentioned aren't improving with rest and PT. And then we'll talk about immobilization for each of these. Sometimes we will brace or boot or put them in a cast for a short period of time. And then prolotherapy is also a potential treatment for some of these too. All right, on to the star of the show. So Osgood-Schlatter's disease. So you'll see a large age range here, so 11 to 17. And I would say most of your cases are going to be between 12 and 15, but you do see some of those outliers. Activity modification, these are very low risk for avulsion injury. So very rarely are we ceasing their participation in sports, but occasionally if they're really severe, we may have to brace them in a straight leg brace for 4 weeks. Some of the more recurrent cases, you may even consider casting for a short period of time. One of the surgeons I used to work with in Denver would do this for recurrent cases. Plus or minus Chopat strap. So that's that patellar strap that we use for, jumper's knee. You can also use it for Osgood-Schlatter's. Remember, it goes on the patellar tendon, not at the inferior pole of the patella or on the tibial tubercle. So it needs to be on the tendon itself. And then prolotherapy is an option for treatment of Osgood, but we'll go through that in a study here. And then occasionally these kids, very few and rare, but occasionally they will need surgery to remove an osseous fragment later on. And a lot of the surgeons will go in, remove that fragment, the inferior patellar bursa, and maybe even a piece of the bony prominence later in life if they still have symptoms after they're skeletally mature. So let's talk a little bit about prolotherapy. So this was a study. It seemed like it just came out last year, but I'm dating myself. It's now been over a decade since this study was published in Pediatrics in 2011. But hyperosmolar dextrose injection for recurrent or recalcitrant Osgood-Schlatter's. So they had girls and boys in this. You can see the age ranges there. They were randomly assigned they had 3 groups. So the first group was the usual care, and this was under the supervision of a physical therapist. And then they had 2 other groups, and these were double-blind injections. One was just with 1% lidocaine, and then another group had 1% lidocaine and 12.5% dextrose. They did injections on these kids monthly for 3 months. And then they also offered them to have additional injections monthly if needed, if they were still having symptoms. And what we see is 65 knees or 54 athletes were treated. And in the usual care, 3 months out, they actually were worse than the ones that had dextrose injection and lidocaine injection. So they had more unaltered sport in those 2 injection groups. They also saw asymptomatic sport was more frequent in the dextrose treated rather than the lidocaine and the usual care. And then a year out, they also touched base with them, and the dextrose treated knees were better off than lidocaine only and only usual care. So pretty good study, 54 athletes, 65 knees. This got everyone's attention in pediatric sports medicine at the time, and we do offer this as a possible treatment modality. But the thing is, you get a lot of kids that have, aversions to needles and have a lot of needle phobia. And that's probably not the treatment for them, of course. All right, on to SLJ, so Sinding-Larsen-Johansson syndrome. Now you'll notice that the age group is much different here, right? So we're at 8 to 12 years of age rather than your 11 to 17 that we see in Osgood. So this is a younger age. This is where the growth plate in the bottom of the patella, inferior pole of the patella, is open. It's the same mechanism of injury, gradual onset of pain, just like Osgood, but it just develops at a different location. So the treatment is fairly similar. We can use a Chopat strap or patellar strap, but you have to make sure you educate them on placement, because sometimes these younger kids will put it right on that inferior pole of the patella and make things worse, right? So talking to them and counseling them is really important. Rarely immobilization is needed, rarely surgical, very low risk of avulsion injury. Most of these can be treated at home with a good home exercise program. And if that doesn't work, of course, you can jump to a formal PT program for them as well. All right, Severs. So if you do any sports medicine over the years, this is going to come into your office quite often. I think I may see 5 to 10 cases of this a week in some weeks. But let's talk about this. So age is pretty similar to SLJ. So we're kind of that 8 to 12-year-old age range. We do activity modification, symptomatic treatment. Soccer players and gymnasts, really common for these guys. So soccer players have a very thin plastic cleat, not much cushion, and a lot of running. Gymnasts don't wear any shoes when they're pounding on the mats and the gym floor. So there's two reasons why we see this, right? So it's the impact of the inferior pole of the calcaneal apophysis here from running and jumping. And then if you have tight heel cords, tight gastroc, you get a pulling effect more proximal or more superior on that calcaneal apophysis. So there are a couple of things you need to address when you're treating Severs. Of course, we use heel cups for most of these kids for short term, of course. And then there's something called an Achilles chopat strap that I started using about 6 or 7 years ago. This seems to help more with the runners than the gymnast. But these are kind of trial and error. So you try the heel cups. If it doesn't work, you may jump to the Achilles chopat strap and see if that works. Either way, you're not going to be able to get both of these into a shoe. And just because the volume of a cleat is not going to allow that. There are other things for barefoot athletes or gymnasts. So this is the X brace. And then you also have the Tully Cheetah, which is basically a heel cup in a neoprene ankle sleeve that allows the gymnasts and tumblers to use these. You have to be a little cautious with these, especially the Cheetah. It can make the balance beam a little slippery, and you can have falls off the beam from using this. Of course, PT is also really focused on eccentric strengthening, but don't forget about the entire posterior chain with flexibility. I think a lot of people think, oh, if you just increase the flexibility of the gastroc, the soleus, this is going to help significantly. And then they fail to think about the hamstring. So it has to be the whole entire posterior chain from the pelvis all the way down to the calcaneus. And that needs to be in your home exercise program as well. Now, if they're really severe, they come in limping, they're doing the toe walking into your office, and they can't put any pressure on that heel at all. A lot of times we'll treat them in a boot for about 3 to 4 weeks until they can tolerate it. Of course, you're doing PT at the same time. Another thing I've learned to do over the years is heel care at home. What I call heel care at home is that a lot of these athletes will take shoes off because there's a no shoe policy at home, and they'll walk around in the bare feet on hard floor or hard tile, and that just continues to impact that inferior pole of that calcaneus. So I ask them to get either a pair of shoes that are just for their home, or like a nice big flip-flop or a pair of Crocs, and then they can use those for walking around. Very low risk of long-term issues with this. So you can educate the family, reassure the parents that even if they do play through, moderate pain, low to moderate pain, it's not going to do any damage to the heel long-term. All right, so this is a recent study that was published in Journal of Athletic Training 2022. This was our group at Children's Hospital Colorado. Dr. Sweeney is known as one of the experts in gymnastics medicine across the country. So this was her study. She wanted to see if there's any difference between the X brace and the Tully Cheetah in our barefoot athletes or our gymnasts. So looking at young athletes 7 to 14 years of age, basically did self-reported assessments after diagnosis, 1 month, 2 months, 3 months out, using the Oxford Ankle Foot Questionnaire for children, looking at physical score, also looked at school play, emotional scores, and then VAS scores as well. Basically, after 3 months, comparing the two braces, there was no significant difference between the physical, school play, emotional scores. VAS pain scores during ADLs and sports were significantly lower or better at 2 and 3 months out compared to their baseline. So conclusions basically both work better than nothing, but no significant difference between the two. All right, another paper, seems like a ton of apophysitis papers come out in 2022. So here's one from the Journal of Orthopedic Surgery and Research on Sever's disease in adolescent athletes. This was in a German youth soccer academy looking back over 10 years. I thought this was an interesting study. So they had 612 players in this study, but only 22 cases of Severs was reported over 10 years, which I think is extremely low. The incidence was reported at 0.36, so per 100 athletes per year. Mean age is not surprising, so at 11.8. Complaints were more in unilateral in 20 and in bilateral in 2. And then we saw that there was 22 cases where there were recurrent injuries. Return to play, this I thought was very interesting as well. 60.7 plus or minus the 65, but 60.7 days for return to play, which to me is really long for Severs. Most of these kids we can get back to play pretty quickly, if not right away. And then they did not see any significant difference in BMI or time of diagnosis with impact on return to play. So I don't know if their athletes just knew if they would report heel pain, they'd be held out for 2 months, and so they didn't report it. But they're reporting very, very low incidence of Severs. All right, on to Iselin's disease. So this is an apophysitis at that base of the fifth. So when you're looking at x-rays of this area, they can be a little confusing. When that growth plate, and you see this linear line, this lucency, and you can see how it's parallel to the long axis of the fifth metatarsal. That's normal. That's not typically a fracture. Now, there may be in this x-ray a little bit of a pull or a little bit of a traction injury that you're seeing that would go along with Iselin's disease. But a fracture in that area is typically going to be a transverse fracture to the long axis of the bone. With these, same type of treatment, activity modification, strengthening, eccentric with that peroneal brevis, working on making sure you have good neutral alignment of the ankle. Cam boot can be used. Some of these kids will come in walking on the medial aspect of their foot, and they can't put any pressure on the lateral side. Sometimes we'll put them in a boot for 2 to 3 weeks just to get things to calm down and then get them in the PT. All right, on to the pelvis. So the anatomy of the apophyses here. So we have a lot going on. So at the very top, we have the iliac crest, and then the ASIS, AIIS, ischial tuberosity, lesser trochanter, and then the greater. Just this last week, when we were at the Pediatric Research and Sports Medicine meeting in Denver, there was a case presented on an overuse injury, almost like a compression stress injury to the lateral aspect of the greater troch apophysis here. And they had beautiful x-rays showing some widening, maybe a little sclerosis in that area, and then an MRI after that showing edema and inflammation across the area. So that was the first case of that I've seen, but I just want to make sure that people are aware that you can get an overuse injury in that growing bone. So ischial apophysitis, pain and tenderness over the origin of the hamstrings, your sim-IT, sim-IM, and also the biceps femoris. Some swelling can be possible. I don't typically see that. Usually no bruising in the area unless there's an avulsion injury. Radiographs can be normal, especially in the younger kids, but they may also show some slight widening of the apophysis. Treatment, activity modification, these are high risk though for avulsion fracture. So we will shut them down, especially in the high level gymnasts, high level athletes. If we don't shut them down, they definitely have a higher risk for pulling off that apophysis. Typically it takes 4 to 6 weeks, somewhere in there, before they're pain-free and they have good biomechanics. And we feel after they get through the return to sport criteria, we'll slowly get them back to sport. Physical therapy really should focus on pelvic stabilization, decreasing any pelvic tilt or protraction or retraction of the pelvis. All right, another study from 2022. All right, Orthopedic Journal of Sports Medicine. This was looking at apophysitis in young male soccer players and elite soccer academy over 7 seasons. They found 210 apophyseal injuries that were documented. Most of these were simple, what they call simple apophyseal injuries or apophysitis, and 38 were avulsion fractures. You can see the rate of injury, 0.35 per 1,000 hours of training exposure. Most of the cases were primary injuries. Some were re-injuries, about 7%. They actually used ultrasound most commonly to diagnose these. They reported the most common location. Now, this is, again, apophysitis and avulsion fractures. The most common location was the AIIS. They did see return to sport faster in those athletes with injuries to the ischial pubic ramus and also with simple injuries or apophysitis in the younger athletes. All right, let's talk a little bit about acute apophyseal avulsion injuries. So like we said before, this is typically a sudden violent muscle contraction, so sprinting. So we see this with sprinters coming off the blocks. I see a lot of these with baseball players. They'll hit the ball and then run as hard as they can, of course, to first base. It's usually within those first couple steps that they feel pop, they drop to the ground and they can't get up. Tenderness over the apophysis, of course. And with that history, with that story, you're going to treat this as an apophyseal fracture until proven otherwise. Even if your x-rays are inconclusive, you're thinking about getting an MRI on this athlete. Some of these can be quite extensive with quite a bit of ecchymoses. They're very tender. Pain over the origin, of course. Weakness with resisted extension of the hip. Weakness with flexion of the knee. Passive stretching can cause pain. And some of these can be missed. We've had some athletes that do not want to report where the pain is. And they'll say it's like lower down in their hamstring. And they don't want to report where it is at the attachment site. So just be cautious of that with your teenagers. Some other things to consider with this avulsion injury. We see this from parkour as well. So that really high eccentric load when they're landing on the ground and they'll feel a pop. We've also seen it with hyperstretching events, competitive cheer coaches, what they'll get on top of the athlete, put their leg up on, maybe not this high, but put their leg up on some mats and then push down. The coach will actually push down on the shoulders to try to get a hyper stretch going on. We had a case with a cheerleader in Denver that had an avulsion fracture happen from that mechanism. So something that you may want to talk to cheer coaches about if you hear that they're doing it. Epidemiology of these avulsion injuries. This data is dated. It's over a decade old, but 54% of hip and pelvis avulsion injuries are thought to be from the ischial aspect. Soccer and gymnastics more common. Plain films, we usually get an AP. I'd like to get the false profile view as well. I just like that view down onto the ischial tuberosity where I can see the growth plate in a different plane. And sometimes it can look different than the other side. Where your AP view, it may be hard to tell. So this is an example, of course, of a very large avulsion fracture, but just to give you an idea of how big these can be. One of the complications with this, we had a patient that with a large piece wasn't fixed surgically. Our surgeons didn't feel like it needed to be fixed, but over time with the osseous formation and callus formation from the healing, the young man started to get penile numbness from pudendal nerve entrapment. So that a rare case of complication from this, but something to be aware of. And then looking at an MRI of the area, you can see all the edema and the little avulsion piece on the right. Usually you don't need an MRI to diagnose this. The x-rays are fine if you can see it, but it can be helpful again in young kids where the apophysis is not completely ossified or where you just cannot see it on plain films. CT can be used as well, but of course we like to stay away from CT scans with our younger athletes from radiation exposure. And as you saw in one of those studies, ultrasound can be very effective in skilled hands and much less costly, of course. It's just a reminder of locations of muscle and tendon attachments, ASIS, sartorius, and then the AIIS, which is on the right side here, rectus femoris. All right, on to another case. We actually wrote this up. This was a case report of two athletes that we saw in Denver. We published this in 2018 with our hip surgeon. We actually had two avulsion fractures of the AIIS that went back to play prematurely against our recommendations. The one had a recurrent injury, another pull injury to the AIIS. The other one had a traumatic injury from a football helmet right onto the area. But both of them developed this exostosis, and it's you can't see it as well in the plain films on the left, but if you look at the CT scan here in the middle, if you look at the left side and focus on the femoral head and the acetabulum, and then come back over to the right side, you can see how much of a bony prominence there is and how much kind of over coverage there is on the front of that hip joint. And then looking at the MRI on the very far right, you can really appreciate this exostosis formation over the AIIS. And you can imagine that hip, when you get into 80, 85 degrees of flexion, you start to get this extra-articular impingement. And then, of course, the labrum is at risk as well. So we started calling this the anterior horn of the pelvis after we saw two of them. And our surgeon, Dr. Novaes, did go in and excise these and then reattach the rectus femoris onto the area. And then after several months of physical therapy, they both did extremely well, but definitely something to be aware of that can happen. Treatment for these injuries, typically conservative. You will see the number of less than 2 centimeters of displacement. I'll tell you that most surgeons would probably be comfortable even up to 3 centimeters of displacement. I very rarely see these go to the OR. If it's a really large fragment, that may be a little bit different story. Or if they're failing conservative treatment, or, we've seen some of our high-level D1 athletes when they're, young and freshmen, into college and have an injury like this and then have surgery for it. We had a case, another case in Boulder, actually, that a kid had an avulsion injury and then a couple months later had another avulsion injury and then came to see us. We tried just non-operative management for 6 months, basically plateaued and couldn't get any better. I talked to our hip specialist there in Boulder, and we decided to go ahead and do a round of PRP injections. So we did those 1 week apart. This is not fun for the athlete, by the way. You're injecting down into the apophysis, which is, even with medication around the surrounding area, numbing the area, you're still going to have quite a bit of pain with these PRP injections. I was actually in the room for these injections, helping the patient out. But either way, after these 2 injections, the kid went back to PT, and after 4 to 6 weeks, he was pain-free and was able to return fully to soccer. So that is an option as well. Not a lot of literature on PRP injections, though, into the apophysis. Crutches are usually needed for a week or so, and they can weight bear as tolerated. Physical therapy can be started fairly quickly with gentle range of motion and strengthening, but usually it's 4 to 8 weeks of good physical therapy. And then if they're looking okay at 8 weeks out and asymptomatic, good biomechanics, we start that gradual return to sport process. Some discussion at the PRISM 2022 meeting was about recurrence of or refracture rates with these athletes if they return to sport in that 6 to 8 week time frame. And it seemed like most people around the country were starting to push that out more to that 10 to 12 weeks. Well, we don't have any great studies looking at this. So if you guys are interested in doing a research project, this would be a great one to do, looking at return to sport and refracture rates for these athletes. But I think most people are now pushing that out to the 10 to 12 weeks to decrease risk of refracture. So tibiotubercle avulsions, 15-year-old girl in a sprint race feels a sharp blow to the front of her shin. She doesn't hit it on anything and nothing hits her. And she has localized pain and swelling right over the anterior knee, over that tibial tubercle. And she has a hard time weight bearing. She can't fully extend the knee. MRI later on showed that this was non-displaced and the tendon was attached. So was treated non-operatively, but this is just an example of a tibial tubercle avulsion. Now, these can be pretty severe and involve like 30 to 40% of the anterior proximal tibia and be kind of hinged off the tibia. So those, of course, would be surgical cases. Here's our fracture equivalent to SLJ. So this is a 11-year-old male, actually was on a scooter. The scooter handle struck the front of his knee as he was falling and had this injury. So you can see this patellar alta and the inferior pole of the patella being disrupted and pulled off the inferior aspect. So these cases, when it looks this bad, are going to be surgical. But some of them are non-displaced or minimally displaced and may be options for non-operative management. We almost always get an MRI for these. The surgeons, if it's a case like this, want to see the posterior aspect of that piece of inferior patella because that's where the chondral surface is, right? That's where the articular surface is. And when you're doing surgery on this, you want to make sure that's all lined up appropriately. But if they're non-displaced and you have an intact extensor mechanism, that may be hard to know right off the bat because they're pretty painful. But if MRI shows that it's intact, you can treat these non-operatively. Now, it's a long process. We immobilize for 4 weeks in a cylinder cast or a straight hinge knee brace locked in full extension. Then after 4 weeks, we open up their brace and start physical therapy and then go through the process of gentle range of motion, quad activation, strengthening, going through all the steps. And then at 8 weeks out, we typically bring them out of the brace and then start a little bit more aggressive physical therapy. And by 3 months out, they're typically ready to start the gradual return to sport after functional testing, of course. So these are big injuries. And if you go back to sport too soon, of course, there's a risk of it being a displaced fracture. And then we get this may not be the best x-ray, but you can see, I don't know if you can still see my cursor, but there is a little lucency that goes through the base of the fifth here. Now, this area is the normal apophysis, so that's not the fracture, but this line is the fracture line for this acute avulsion. And of course, this is an inversion injury presenting with tenderness, bruising, swelling over that area. Typical treatment, 4, sometimes 6 weeks of cam boot, usually 4, followed by some physical therapy as well. Of course, you have to watch out for your pseudo-Jones and Jones fracture in this area, but you can see this is pretty far proximal. Onto the elbow. So medial epicondyle apophysitis, also known as Little League elbow. Of course, the Little League Association doesn't like us to use that terminology, but it's had that name for quite some time. Repetitive overhead throwing. This is an attraction apophysitis at the medial epicondyle ossification center. That ossification center opens around 6 to 7 years of age and then fuses around 15, so open for quite some time. The MUCL and the flexor pronator tendons originate onto that ossification site and also help provide valgus stability to the elbow. And as we know, through the late cocking, early acceleration phases of the throwing with young athletes, we get a lot of stress to that elbow and that valgus position. These are at risk for avulsion fracture, and they do require rest from throwing. So we do shut them down from throwing. We allow them to play first base as long as they're not doing any overhead throwing. Most of them can bat and condition and do all those things without risk of further injury. We do have a lot of baseball players that also play basketball, and they have a question: can they play basketball with this? I tell them if it's a different mechanism, when you're shooting a basketball, if you can do it without pain, I'm okay with you doing it. But if it causes pain, then I rest them from that as well. This is actually one of the best papers that we'll talk about tonight. So this one, also in 2022, Journal of Shoulder and Elbow Surgery, was published, May of 2022. Okay, so influence of chronic medial epicondylar apophysitis on medial ulnar collateral ligament insufficiency later on. So they had over 3,000 high school baseball players enrolled into this. Now they used a self-reported questionnaire to talk about history of elbow pain, and then also elbow pain in the previous season. They did physical examination to assess the tenderness over the MUCL, and also did a valgus stress test. They used ultrasound to look at the morphology of the medial epicondyle and determine kind of like the degree of injury to that anterior-inferior aspect of it. So participants with findings of chronic medial epicondyle traction apophysitis had significantly higher prevalence of past history of pain, pain with or during the previous season, tenderness over the UCL, positive valgus stress test compared to those that did not have findings on ultrasound. They went on to conclude that the presence of chronic non-healed traction apophysitis at the medial epicondyle was significantly higher risk in baseball players for long-term elbow pain and UCL insufficiency. All right, so take-home points from apophysitis: gradual onset of pain, tenderness over the apophysis without an acute injury, likely apophysitis, right? Acute injuries, and they may have a little bit of pain in the area before, but big pop, can't use the leg, drop to the ground, or like dead arm, you're thinking avulsion fracture. All right, Matt, how are we doing on time?
We're just coming up on, we've got like 17-ish minutes left.
Perfect. All right.
Strong. Yep.
Excellent. All right, so osteochondrosis. So we have 4 of these we're going to talk about tonight. As you'll see here, this is the capitellum of the elbow, and you can see some irregularity kind of throughout the entire ossification center. So this is a case of Panner's, which we need to distinguish between what you probably hear about more often is OCD of the capitellum in young throwers. So Panner's happens at the age of 5 to 10. So we're talking about much younger patients, almost always in the dominant elbow in boys. It's an avascular necrosis of that capitellum. We don't know for sure, but we think it's due to chronic repetitive trauma, and there may be some hereditary factors. But with all of these osteochondroses, we don't know exactly why they occur. Symptomatic treatment is usually sufficient. The capitellum will revascularize and develops normally over time. So very rare for them to have long-term issues from this. But the area is the thing that helps differentiate it from OCD, right? So the entire capitellum is affected, where in an OCD, it's the chondral surface and the subchondral bone. Age, usually OCDs are a little bit more, like more mature kids, so maybe 11, 12 or older. And then the cartilage in Panner's is typically normal. All right, so this is, so both sides are affected, but I want you to look at the midfoot region here and here. So left foot more affected than the right, younger kid. So this is an example of Kohler's disease. This is also an avascular necrosis of the navicular, much more common in boys, so 4 times more common in boys. Younger kid, 4 to 7. I've even seen it down into 2 years of age. Bilateral and up to 25% of the cases. These also do extremely well in revascularize over time, but they may need NSAIDs in a short period of immobilization. Sometimes we'll put them in a little boot or a tiny weight-bearing cast that doesn't slow down these kids. They're still running around like crazy in their boot or cast, but at least it provides them some symptom resolution or symptom control, and usually resolves over time. You may have to do some activity restriction for months to maybe up to a year, but then it goes away. All right, for this one, I want you to focus here on the head of the second metatarsal. So this is a classic case of Freiberg's. Little different age group and more common in females. So female adolescent athletes between 13 and 18, 4-to-1 ratio between male and female, or female and male. This is infarction of or fracture of the metatarsal head, again from avascular necrosis to the area. We see these more common in dancers, especially ballet dancers, where they're putting a ton of stress through that area of the metatarsal. The second, more common, we've seen it in 4th and 5th, but rarely. And I've actually had a case where it was just in the 3rd metatarsal, kind of a rare presentation. Treatment is activity modification and NSAIDs, but these can go on to have some joint destruction and joint deformity and maybe even need surgery. And the surgeries aren't perfect for this either. This one's a hard one to treat. And I know there's people in the audience like Dr. Canty has probably seen this and knows that this is pretty tough because this is a patience game, right? It usually takes at least 6 months, if not up to 2 years for this pain to go away. That's a long time for a young dancer to have to do activity modifications, or a young soccer player or something like that. So you get to know these families well, and unfortunately it takes a while to heal. And then the last one is kind of a slam dunk case here, right? So looking at that left hip, you can see flattening, irregularity of the femoral head. So this is your Perthes disease, avascular necrosis of that proximal femoral epiphysis. Younger kids, 4 to 8, male to female, 5-to-1, bilateral on 12%. Family history can be a risk factor for this. Treatment for those kids less than 8 years of age is typically observation. For those presenting greater than 8 years of age, unfortunately, usually require some degree of surgical intervention. These kids really need to be seen and treated in a hip preservation clinic or by a specialist that does this. All right, so we're on to our CAQ question number 1. This question, I will tell you, is a little unfair because it's an apophysitis talk. So I'm going to give you a little heads up on this one. Matt, do you want to read the question?
Yeah, alrighty. So a 7-year-old male soccer and baseball athlete presents with a 4 to 5 week history of activity-related left anterior knee pain. He describes the pain as peripatellar. He reports slight swelling, but no mechanical symptoms or instability. There was no injury. He has had no fevers, other joint pains, or swelling. His examination is remarkable for pain and tenderness diffusely around the patella. The remainder of the examination is unremarkable. Initial radiographs are shown. There was no improvement with activity modification, physical therapy, and conservative measures. An MRI was obtained as shown, including Sagittarius and axial images. What is the diagnosis? A, chronic recurrent non-bacterial osteomyelitis. B, patellar fracture. C, Sinding-Larsen-Johansson syndrome. D, symptomatic bipartite patella. Or E, osteochondrosis of the patella.
And I apologize, we don't have the axial images of the MRI, and that can be a reason if you missed this. So looking at the MRI on the top right, I can tell you that you see quite a bit of edema throughout the entire patella. So the key words here, peripatellar pain and tenderness diffusely around the patella. So we'll give you about 30 more seconds to submit your answers. All right, Andy, are you going to tell us the results? Oh, perfect. Okay. Yep, sorry. I knew this was a trick question because this is a apophysitis talk, but I'm glad we talked about it. All right. So yeah, SLJ is what we talked about in the talk. The answer for this one is actually osteochondrosis of the patella, which is a very rare condition, but something you should know about. So let's talk about the differences between SLJ and osteochondrosis, also known as Kohler's disease of the patella. So this is where it's peripatellar, or the entire patella is painful. The MRI shows that there's edema throughout the entire patella, which is different from SLJ, right? SLJ is going to be pain just at the inferior pole of the patella, and not in the peripatellar region. If you get an MRI, you would see edema at that inferior pole, but not entirely throughout the patella. So apologize, that was a little bit of a trick question. They'll be a little bit more straightforward from here on out. All right.
All right, question 2. A male child presents with the insidious onset of, moving the poll over, posterior heel pain a couple weeks into his soccer season. The pain is exacerbated by activity, especially running and jumping. Pain improves with rest. On exam, he is tender to palpation over the posterior heel and has tight heel cords. You determine that his pain is most likely related to apophysitis. What is the most likely age for presentation of this condition? A, 5 years old, B, 7 years old, C, 10 years old, or D, 17 years old.
This one should be pretty straightforward. So we can probably look at the answers now. Yes, exactly. So 10 years old is the range is 8 to 12. You could, I've seen it down into 7-year-olds, so those answers are not terribly off. 5 years old, 17, definitely outside the range for Sever's, but 10 is right in the middle of the age range. So think about this. If you have a 10-year-old that comes into your office with heel pain, it's like 98% of the time, it's going to be Sever's, right? The other things to consider would be tarsal coalition, and that's something to look up and be aware of. You can get a UBC or an ABC, so some different cysts, bone cysts that can develop in the calcaneus. They usually present with pain throughout the entire bone and some swelling. But the the tarsal coalition, where you get like calcaneal navicular coalition, that can present fairly similar as well. Right, so classic presentation of Sever's commonly affects kids 8 to 12. Younger kids are more risk for Kohler's and Perthes, and then they mention Osgood-Schlatter's 10 to 14, and we know that's a little bit older. All right.
Question 3. A 15-year-old female soccer player complains of right hip pain. Her pain began 1 week ago after running sprints at soccer practice. Lifting her leg, flexing her hip, and running make the pain worse. On exam, she is focally tender over the anterior superior iliac spine. Pelvic x-rays reveal that she is skeletally immature. We diagnose her with ASIS apophysitis. Which muscle originates at the location of her injury? A, sartorius, B, rectus femoris, C, biceps femoris longhead, or D, gracilis?
Oop. There you go. Slipped. Yeah, that's what I get for trying to look at the chat. All right. Yep. Sartorius. Perfect. So let's close that. So sartorius attaches onto the ASIS, the rectus femoris onto the AIIS, the gracilis is onto the pubic symphysis, and of course your hamstrings onto the ischiopubic rami or the ischial tuberosity. So, all right, I think that's all of our CAQ questions for the night. So do we have some chat questions here?
Yeah. Thank you for that excellent talk, Dr. Provance. As far as questions, Concon asks, can you provide some specific guidance on the activity modifications for dancers with Freiberg's? For instance, dancers who are doing on-point work.
Yeah, excellent question. Concon was our fellow last year, so good to see you on, Concon. Hope things are going well at LSU. So yeah, great question. And this is something that is always a long discussion with the dancers in the clinic. It depends on the time frame of when they present and kind of where they are in their stage of healing. I do recommend serial x-rays to kind of watch for recalcification and revascularization of that area. And typically that will be consistent with their pain. As their pain gets better and better, you'll start to see some recalcification of the area. But as far as if it's like in the acute phase and you're just diagnosing it after 1 to 2 months of pain, typically the x-rays are not going to look very good. And we usually cut out any significant like twisting or leaps or turning. Most of your point work, unfortunately, is going to have to come to a halt. But they can mark, they can go through choreography. But you may even be talking about like a cam boot or even a hard sole shoe to get their pain under control acutely. Now, as they progress and get better over months to a year or so, then you can start to introduce some of those activities, and eventually get them back on point. But it's always depending on their pain levels and what your x-rays look like. So it's going to be it's variable over the time spectrum, and not all of these heal exactly the same, right? So it's hard to answer exactly when I would let them get back onto point.
Thanks for that.
Mm-hmm.
On the topic of activity modification, I feel like so much of the management of apophyseal injuries involves some degree of activity modification and sometimes even full rest in these high-risk locations. So how do patients and parents respond to this recommendation?
Variably. So some of them completely understand and are very good. And then, and a lot of times if we're having some troubles, with compliance with the athlete, or the parents are quite upset that they're going to have to stop throwing in baseball. It's usually dad, that's the baseball coach, right, in the room with you, and talking about his star pitcher, who's his son, and shutting him down mid-season doesn't go over so well. But when you really sit down and take the time to then even just give them examples and show them x-rays of what an avulsion fracture would look like off the medial epicondyle, and talk about, if that happens, what the surgery looks like, what the recovery looks like. I think that goes a long way. Pictures say 1,000 words. And when they see that, they're just like, oh, okay, we don't want that to happen. And it may take a couple visits to really get it home, but usually they're pretty receptive. And these visits are probably going to be your 30-minute to 40-minute visits. But it's good to take the time to explain things.
I see what you mean. As far as these kind of elite level pediatric athletes, have you noticed apophyseal injuries presenting at earlier ages as pediatric athletes tend to be stressing their bodies earlier and earlier, or is it kind of dependent on when the ossification center opens?
Yeah, great question. I actually failed to mention that during my SLJ slide, so thanks for reminding me. I over the years, and I don't have any data to support this, I'd like to hear maybe what Dr. Canty has, his experience as well. But over the years, I have definitely seen more SLJ in our younger athletes coming in to see me. I've definitely seen more severe cases of like SLJ and Osgood-Schlatters come in. Even Severs come in to see me, where they're just constantly pushing through really high levels of pain, and then we'll have to go immediately into a cast or a brace or a boot for quite some time. We had a young athlete that was a level 10 gymnast, and she had SLJ so bad she actually eroded the patella. So the anterior aspect of the patella, she basically eroded a ridge in the patella because she was pushing through so much pain. It took us almost a year to rehab her and get her back to sport.
That's good to know. Okay. Follow-up question as far as diagnosing apophyseal injuries. And this comes out of the study that you mentioned from the German Academy, and they were using ultrasound, for instance, to differentiate and to diagnose. What kind of things would you expect to see on an ultrasound for an apophyseal injury?
Yeah, good question too. So a lot of times you'll see fragmentation, or you may see some edema in the area as well. I'm old enough, I don't use ultrasound as much to diagnose apophysitis, but I typically, base it on clinical examination. But if you're looking for an avulsion fracture, I think that's going to be a little bit easier to see on an ultrasound.
Okay, and I think one more question. This is from Michelle Henn. Do you manage Hegemans differently from Panners? And for Kindbox in pediatric athletes of lunate, how long do you immobilize prior to starting a rehab program? How often do these do well with conservative treatment?
Yeah, so with the Kindbox, so that is the avascular necrosis of the lunate, as mentioned in the question. A lot of these we start to rehab pretty early. I usually do immobilize them, but because they can have long-term complications, that's a condition that we usually don't manage in our clinics. If we diagnose it, we will send it over to our hand team to follow long-term, because they can. We had a case recently that came in to see us after like a year of pain, and diagnosed Kindbox, and there was complete destruction of the bone, and the proximal carpal row was unstable. So a lot of these I will send off to hand to watch. And then the first part of the question, I don't manage them very differently at all. It's very similar treatment.
Okay, well, we've got a couple minutes over the hour mark, so I think we'll wrap it up here. Thank you again, Dr. Provance. That was an excellent talk. And thank you again to AMSSM, Andy, for putting this on, and for everyone for tuning in tonight.
Thank you, guys.